So, good evening and welcome back, everyone, again. So, in last session, we were discussing regarding the benchmarking and the HCAP surveys. So, continuing from there, within the same topic, today we are going to discuss clinical practice guidelines, clinical pathways, clinical reviews, credentialing, and privileging, and everything related to it. So, let's start. So, in today's session, there are two subsessions. In the first part, we'll be dealing with clinical practice guidelines and clinical pathways, what they are, how they differ, and how they actually help us standardize the care and improve outcomes of for the patients. And in second part, we'll be moving into professional practices like peer review, who licensed independent practitioners are, what's professional evaluation is, OPP and FPP. Then we'll look into credentialing, privileging, re-credentialing, appointment, reappointment, as well as the practitioner profiling. Okay, so in today's session, there are about somewhere around 3 to 4 very important sort of concepts as far as the exam is concerned. So this is simple and straightforward topic. Now, we'll start with evidence-based practice or EBP. So evidence-based practice simply means we all know that we are not treating patients based on our own habits or traditions or what my teacher taught me or what my senior did years ago. Okay, instead we integrate three things, that is the best available research evidence and our own clinical practice and expertise, as well as the values and preference of the patient. These three pieces form evidence-based practice. Now, here's the challenge. So there's a huge amount of scientific evidence out there, thousands of articles, guidelines, trials, and everything. But practically, we all know no individual or no clinician can actually read everything. So we need a way to translate all that evidence into something practical, right? So that's where clinical practice guidelines, or CPGs in short, come in. I hope you understood now what CPGs are. Clinical practice guidelines are systematically developed statements that help practitioners to make decisions about appropriate healthcare for specific clinical circumstances. That's as simple as that. But remember, systematically developed means they are not random opinions, but they are built through a formal process of literature review, reviewing the evidence, assessing benefits and harms, and also this process involves the experts. Okay, so in short, CPGs are evidence-based recommendations, okay, which guide what we should do in common clinical situations. That's the entire gist. Now, you may have come across someone stating the hypertension guidelines, diabetic guidelines, these guidelines, that guidelines, or when a clinician is treating community-acquired pneumonia, or when they are trying to prevent VT or venous thromboembolism, they are following certain guidelines, right? So the guidelines pull together the best evidence and say in simple terms, like for patient who looks like this or who has this, here's the recommended approach. That's simple. Now, why should we have them? What's the purpose of clinical practice guidelines? The core goals for having CPGs are to standardize the care and to improve patient outcomes. Okay. And also to reduce unwarranted variation in practice. So, when we use well-developed guidelines, we are less likely to miss important steps, less likely to provide unnecessary or harmful care to the patient, right? And we are more likely to achieve consistent good outcomes for the patients we treat. But remember, guidelines typically describe the typical treatment for typical patients which support reliability and predictability. So this is in general. This is not customized for every patient. We'll be dealing with that soon, right? So it's for typical treatment for typical patient. These are the broad guidelines which the clinician should be following, but there should be some room wherein the expertise of the clinician should come into play, and will try to adapt to the situations from different patients that he comes across. So this is not something blindly to be followed. Okay, that's situational. I mean, like, these are the broad guidelines. He should be sticking to it, but we'll have to look into the circumstances of the patient as well, right? So remember, standardization doesn't mean every patient gets the exact same care. Okay, so we start from solid evidence-based baseline from the guidelines, and then we try to individualize based on different patient factors. Now, coming to advantages and disadvantages of CPGs. Let's look at the advantages first. We already know standardize, practice, and reduce unwarranted variation. See, the more you reduce variation, the more you reduce the cost. How? If every, let's say in your hospital, if every doctor treats the same condition, like let's say for a department, there are multiple doctors. And if every doctor treats the same condition in completely different ways, going for different tests, ordering different drugs, obviously there will be varying degrees of lengths of stay for these patients, right? Even for the same condition. In such situation, what you're going to see? You're going to have waste of resources. There will be confusion for the staff. And there is a risk to patients because care is unpredictable. But when you use guidelines and pathways to reduce this unnecessary variation, here again, we are not talking about clinical judgment. We are talking about unjustified differences. Okay. Justified variations are absolutely fine. Clinical judgment is absolutely fine. But we are supposed to reduce unnecessary variation. That's one of the biggest advantages of clinical practice guidelines. Okay, so reducing variation is not about limiting the clinicians again. It's about everyone around should be having the best practice so that we are not reinventing the wheel with each patient. Okay, so we are, like, again, for you to understand, if every patient with heart failure gets totally different treatment depending on which doctor is on call or which doctor the patient is being seen by in a hospital, and when you compare that to another hospital wherein all heart failure patients are managed according to clear evidence-based guidelines, now let me ask you, which hospital is more likely to have predictable outcomes or the better resource use and will have lower costs? Obviously, the second one, who follow the guidelines, because there's a predictable sort of outcome. There you are going to predict the length of stay, right? And in certain situations wherein there is capitated payment, obviously, that really helps the organization also. And when a sort of the guideline is being followed, the patients will have predictable outcomes. They are risk free. They know that they are being treated with the best of the possible evidence, right? So in a way, like, that benefits both the patient, organization, and also for the clinician. Okay. Now, CPGs also support quality management activities. How? By providing clear criteria for audits, indicators, and performance measurement. Now, when you are into the department of quality, when you are going for an audit, clinical audit for something, how can you actually judge the clinical parameters, or how do you evaluate a particular case? Only when you come across the guidelines related to that particular treatment, isn't it? So CPGs set that thing for a quality management activities. Now, what are the disadvantages? Yes, there are some limitations. What are they? Because guidelines may not fit every individual, especially for patients with multiple comorbidities or rare conditions, this may not be suitable for everything. There might be a guideline which might have been developed or which might have been based on the studies based on a population, given population, or in an age group of certain time. But again, that may not 100% translate into the exact guideline for another age group or for another ethnicity or population. right? There are sometimes that this does happen. So there's another risk. If at all the guidelines are outdated and not regularly revised, obviously your team is practicing obsolete practices. That's a risk. Now, when a clinician actually relies heavily on these guidelines, sometimes it can discourage clinical reasoning if they follow them blindly and they, in a way, like forget that they are there to think, right? So that's one of the risks. And also, CPGs reduce harmful variation but become dangerous when applied to rigidly applied. When they are rigidly applied, they eliminate the clinical judgment they are supposed to support. Clinical practice guidelines are there to support the clinical judgment. They are not there to replace it. So the goal was never zero variation, but just unwarranted variation is supposed to be taken out. Okay. So in a way, like here, remember, there are variable patients that may not be suitable for all, and all these clinical practice guidelines may not respond to individual patient needs. Okay, so that's the reason why CPGs must be evidence in a way, like overall, CPGs must be evidence based. They should be regularly updated and applied with proper clinical judgment. It's as if they are the guides. They're not the binding chains for you. Okay, this is a sort of GPS. While you're driving, you rely on GPS, right? But that's a guideline for you. That's a guide. You're not supposed to blindly depend upon the GPS alone. If you come across some sort of roadblock or an accident happening in front of you, you are supposed to divert yourself from that particular path, which the GPS may not capture, because here you are taking certain decisions because you are able to think, you have discretion, you are supposed to take the decision at that particular time for your benefit, for the better outcome. Okay, in similar situations, the clinicians are supposed to take the patient's needs, patient's situations into account and use their clinical judgment, but broadly follow the clinical practice guidelines. Okay, now let's move to clinical pathways. Sometimes what happens is we all mix these up. We think both clinical practice guidelines and clinical pathways are the same, but no, they are different. Let's see how. So, in a way, like a clinical pathway is a structured multidisciplinary care plan for a specific clinical problem or procedure. Okay, it's designed for a well-defined group of population or patients. For example, these pathways are developed for a specific patient group. Let's say in our hospital, we do have clinical pathway for elective hip replacement, or we do have stroke pathway also, like for patients who are admitted for with stroke. So as far as guidelines are concerned, which are broad recommendations, clinical pathways are actually practical day by day plan. They map out what should happen to the patient during their entire stay. Like for example, in the pathway, I think the pathway like a timeline. In a hip replacement pathway, on day zero, if I say on the day of admission, if it's day zero, there's what are supposed to be done. Admission is supposed to be done. Initial assessment should happen. Then baseline labs should be happening. The pre anesthesia checkup should be happening. Okay, on or let's say on day one, the next day, all the imaging should be completed. In a way, like medication adjustment should happen. Then the anesthetic checkup should happen, and the surgery to be posted on the next day, the surgery day two. Okay, 0, 1, 2. Surgery, what are the things you are supposed to do post-op, and then mobilization on day 3, the next day, discharge planning, patient education, physiotherapy counseling, and discharge to home. In this way, these pathways actually have a practical and day by day plans. It's a complete flow map sort of thing. Okay, remember, in clinical practice guidelines, it's more of about the clinicians, it's about doctors, but clinical pathways is multidisciplinary. Here, doctors, nurses, physiotherapists, pharmacists, social workers, everyone is aligned with this particular shared plan. Remember this. Okay, and one more important thing is clinical pathway is not the standard of care. It means the pathway is a tool. It's not a legal definition of what must happen. Okay, so the standard of care is like more broad, is defined more broadly by professional norms. It's more of guidelines, policies, and regulations. Remember, clinical pathway is not the standard of care. Remember this for your exam too, if at all. That's the thing. This is where you should be knowing pathway, but this clinical pathway sits inside that particular standard of care framework. It's not standard of care itself. Okay, so it's more of a practical implementation tool. What should happen after with step. Okay, in a way, like what happens is, if the guidelines give you the broad things of how to approach a patient with certain condition, okay, here in clinical pathways, it helps you translate those guidelines and evidences into actual day-to-day actions. That's as simple as that. Now, the most important thing is the clinical pathway allows the physician to change, delete, or add interventions to meet each patient's needs. So it is structured but also flexible. Okay. Now, you might think, if pathways are flexible, how do they help with standardization? Right? That might be the question. For such thing, remember, they standardize the expected flow of care for typical patients, while they still allow deviations when clinically justified. And remember, those deviations can be documented and analyzed. Okay. So what are the components of a clinical pathway? Clinical pathway includes goals, interventions, and expected outcomes. Goals are like, what are we trying to achieve? For example, what's the goal of for a particular patient? We are trying to mobilize the patient early. We are trying to reduce the complications. Okay, that's a goal. Then what are the interventions for that particular patient? We are going to go, medications are the interventions, the procedures which we are doing, consultations, the patient education. These are all the interventions. What are the expected outcomes? Expected outcomes are measurable endpoints, like what is the length of stay for this particular patient? What are the complication rates, readmission rates, and how about the patient satisfaction after this particular procedure? Okay, so these are all things that are laid out in a structured format in a day by day phase of care. Right now, from quality perspective, pathways make it easier for us to track whether planned interventions were actually done or not, and it helps us compare expected outcomes versus actual outcomes. And it also helps us to identify the gaps or delays. Once you go through this particular case review, you can actually get all those things happen. You can review everything, what I told now, just because you have a stand in a way like clinical pathway for that particular patient. If not, on what basis are you going to judge it? How are you going to know whether what was the outcome that was expected and what was the actual outcome? Or how do you know what are the gaps that were there in that particular treatment? Or if there was any delay, right? So pathways will help the Department of Quality in that aspect. Okay. Now, what are the benefits? Again, it reduces the variability in the process and outcomes. It improves the resource utilization. It decreases the cost and also enhance the communication and teamwork among the disciplines. Because see, if a patient has come for a hip replacement surgery, if my team knows what is supposed to be done at what time on day 0, day 1, day 2, day 3, I don't have to teach them everything as to what the next step is. So obviously, there's a teamwork, there's a discipline, right? And that enhances the quality of care. All these things are the benefits of clinical pathways. Now, we have discussed what CPGs are, what clinical pathways are. In short, remember, clinical practice guidelines are high-level evidence-based recommendations which are developed through systematic literature review and expert consensus. CPGs aim to standardize the care and improve outcomes, whereas clinical pathways are detailed multidisciplinary plans for specific group of patients. They are more of a operational guidelines into daily practice. Okay. CPGs are like what and why. What should we do and why should we do? And clinical pathways are like how to how to do that and when to do that. Okay. What and why versus how and when. Both are very important for healthcare quality. Now, professional practice evaluation or PPE. Okay, so it is all about evaluating the performance of individual practitioners here. So the peer review is the review of individual practitioners by like practitioners. We have been discussing what peer reviews are throughout the earlier sessions. So it's a review of individual practitioner by like practitioner. Like who is a like practitioner? Someone with the same training and expertise who can evaluate that licensed independent practitioner. Here, the goal is to assess the performance of licensed independent practitioner or LIPs in short, using objective data and expert judgment. See, it involves both objective and subjective things. But subjectivity comes with your, like the like practitioners or the evaluators or the reviewers' expertise in that particular field. It's not random. You and I can't do this. It's only the qualified and the person who is much more senior, who has the same training and expertise in that particular field. Okay. Now, so remember, peer review documents are very much confidential because it encourages open, honest evaluation without fear that comments will be misused. Here, there may be a sort of doubt, a fear among the practitioner who is being evaluated, like, oh, if such so and so person is evaluating me, will these comments go out? What will other people think of? No, here the main aim of this peer review is to keep everything confidential while evaluating because we want an honest and open evaluation without any sort of fear, without what do you say, smearing the sort of colleagues or the practitioners per se. Okay. And peer review is a major component of practitioner appraisal because it helps practitioners identify areas where they are doing well and areas that need improvement. That's the simple analogy I can say. It's more about your appraisal, the clinician's appraisal by someone who is more experienced. But this appraisal depends objectively on the data. What sort of data we'll be discussing later, and with subjective expert judgment. Okay, there are two types of professional evaluation. They are FPP and OPP. FPP is focused professional practice evaluation. OPP is ongoing professional practice evaluation. We'll look into detail in the next slides. Okay. And before going with FPP and OPP, you should know who a licensed independent practitioner is. Okay. So in the United States, LIP is an individual who is professionally licensed by the state and is permitted by the organization to provide patient care services without direction or supervision within the scope of that particular license. Okay. So in short, let's say these are the consultants who are taken up by the organizations who have the privilege and the right to admit the patients under them on an independent basis without direction or supervision. Okay. So the licensed independent practitioner can be anyone who might be a physician, a dentist, okay, or podiatrist or anything who have, depending on the local regulations, they should be licensed by the state, permitted by the organization to provide patient care services without direction or supervision. Okay. Now, remember, only LIP who are appointed have the authority to approve admission of the patients. Like, for example, my organization has taken an ex-physician on board, okay, who is licensed by the local regulation, by the state. Does he have the right to admit the patients under his care, that depends on the privileges which is given by the organization. But for our understanding, LIP, who is formally appointed by to the medical staff by the organization, by the proper governing body and authority, and given the privilege, only has the authority to approve admission of patients. If not, they are mostly called as specialists, registrars, or residents or assistants. Okay. So that's the reason why I told the consultant rank in organizations, LIPs in a way. Now, coming to OPP and FPP. See, OPP stands for Ongoing Professional Practice Evaluation. As the name says, it is continuous monitoring of the practitioner's performance using data. Remember, as far as JCI is concerned, JCI considers evaluation once a year to be periodic evaluation, a sort of not ongoing evaluation, but it's always, but remember, OPP should be done no less than every 9 months, at least 3 times in 2 years. Okay, JCI says once a year, but it should be periodic. But to meet the intent of the standards, OPP reports should be completed no less than every 9 months. Okay, at least 3 times in 2 years. So this OPP uses both qualitative and quantitative data. What sort of qualitative data? Qualitative data is peer feedback, staff feedback. Quantitative means the quantified data regarding clinical outcomes, complications, and readmissions. Okay, so consider this something like an ongoing continuous monitoring of the practitioner's performance. Objective data and subjective data, qualitative and quantitative data. Okay, now it's more like what do you say, continuous quality improvement, CQI, but for individual practitioner, as simple as that. Now coming to FPP, focused professional practice evaluation. In what situations FPP is done? It is used when we need a deeper, more focused review of the practitioner's performance. Apart from OPP, when a new practitioner joins a medical staff, he is supposed to undergo FPP. Or when an existing practitioner requests new privileges, he is also supposed to go through FPP. Or when your OPP data shows significant variation or concerns compared to peers, okay, then also FPPE is required. Okay, in FPP we might use proctoring. Remember that. So proctoring means observation, evaluation, right? So it's observation and evaluation of a sort of new licensed independent practitioner or an LIP with newly requested privileges. It's something like a senior or an experienced colleague watches over the new practitioner directly, okay, to see whether that practitioner is competent and safe enough before being handed over, before giving that sort of independence. Okay, now in a way like let's say there's a department of general medicine, or let's say general surgery per se, and there's a chief who has 30 years of experience, the head of the department. If at all a 2 year newly 2 year experienced general surgeon has joined the team, he will be undergoing FPP, that is focused professional practice evaluation. He will be under proctoring because the chief will be observing him and evaluating him through few surgeries. He will be seeing and then he'll be okay once he gets to know the objective data as to what are the outcomes of the patients, the readmissions rate, complications, and everything, and how things are going with that particular practitioner. If he's fine, then let go. But again, at every 9 months, you are supposed to have an ongoing professional practice evaluation, at least 3 times in 2 years. Though JCS is at least once in a year, 3 times in 2 years is mandatory. But after 2 years or so, if this particular surgeon demands new privileges, earlier he was not doing laparoscopic surgeries. Now he wants to do laparoscopic surgeries because he has undergone laparoscopic training. He comes back and then he asks for certain laparoscopic privileges. Then also he will undergo FPPE. The chief will start observing again. He will be under proctoring, under guidance, under observation, evaluation. And once the outcomes are good, then he'll be allowed independently. And when is FPP brought in again? See, his data is good over the period of time, but suddenly over the past 2 to 3 months, if the complication rates rise or if the readmissions rates rise and the objective data from his ongoing professional from his OPP shows some sort of concern, there is variation when compared to other surgeons, then also he will be undergoing FPPE. Remember this. Okay. I hope you got to understand when and how to do OPP and FPP. Now, coming to clinical reviews, they can be anything: mortality review, morbidity review, or rational use of blood and blood products, medication management, etc. And as name suggests, it can be either prospective, that is before the treatment, concurrent during the treatment, retrospective after the treatment, or revalidation like peer reviews or FPPs. The name suggests what they are and nothing to expand there here. We'll focus on mortality review because as far as your exam is concerned, mortality reviews are the things which is important. Coming to mortality review process, it's a structured way to review cases where a patient has died. The purpose is to determine whether the death was expected and unavoidable or potentially preventable given optimal care. Okay, so here remember this. The scope includes reviewing of the patient's treatment that is provided, the timeliness and appropriateness of interventions, and the level of care. Was the patient in the right setting, seen by the right team or not? Everything is reviewed in that mortality meet. The focus is usually on unexpected mortality. Remember this, cases where the patient's death was not anticipated based on their condition. If at all there was an expected mortality, that's okay, but this is done especially for cases where the mortality was not expected. Okay, so also remember to apply the risk adjustment principles which we have discussed in earlier sessions. Okay, when you do these mortality reviews, because there might be n number of factors depending on the patient or the diagnostic categories, risk factors, age, admission source, etc., right? Or what the condition of the patient at the time of admission was. So risk adjustment is supposed to be done during mortality review. Remember this. Okay, now one of the most important things as far as mortality review is concerned, remember, this is a very important or very powerful quality improvement tool. This is not aimed at blaming individuals. This is one of the take home point. Earlier also we have discussed in the practice questions and the quizzes that mortality review is not done to blame individuals. It's always like, what can we learn from this particular case to prevent similar events in the future? What can we learn from this? What are the take home message so that we can give better care and not fall into the similar trap for the future patients, even if there was some sort of lapses as far as the system is concerned. It's for continuous quality improvement. This is not about blame. The basic thing for the quality, right? Now, coming to credentialing. So most of you who hold a clinical license, whether you be a doctor or a nurse or a paramedic, you do know that you might have undergone data flow primary source verification, right? That is required before you even start your licensing qualification exam and to further the process for your employment. That itself is credentialing. Credentialing is essentially your background check for all healthcare practitioners, right? So in credentialing, they see whether the candidate has a required education like bachelor's degree, which medical school, residency, fellowship, whether he holds valid license certifications, has appropriate experience, right? And is his professional history free from any serious concerns or any disciplinary actions? Okay, so in a way, like in primary source verification, they review your diploma, training certificates, experience letters, everything, including your disciplinary actions. So who does it? That depends. As far as we know, data flow is one thing which we get it done, and sometimes the HR team does it or the medical team does it. Okay, and the report of this particular thing is referred to a credentialing committee of the organization. Typically, this credentialing committee is responsible for determining what credentials are necessary for different positions. Like, for example, what are the credentials that are required for a unit chief, or for a registrar or a resident, or to a specialist, or to a junior consultant, right? So these criteria is developed by credentialing committee. What are the professional standards, license requirements, regulatory guidelines, everything. Now, the most important thing is the credential committee will go through the primary source verification report, the credentialing, everything. They will see whether the candidate fits into this particular requirements or not, and then they will suggest or they recommend that particular report to the governing body, and the final approval of appointment is the responsibility of governing body. Remember, this is one of the things where you should not be confusing. The recommendation for the credentials is given by the credentialing committee, but the final approval of appointment is the responsibility of governing body. Okay, credentialing committee recommends, governing body decides. Now, credentialing is not one-time event. We also have re-credentialing, which is done at the time of reappointment. Now, you may be confused what is re-credentialing, reappointment, re-privileging. See, re-credentialing is a comprehensive evaluation. Again, it requires all information reviewed at the time of last appointment except information that does not expire, such as education achieved. For example, see, simply if the standards say like a practitioner is appointed, okay, that appointment is not forever because healthcare evolves. There are many new things that are coming up. They should be having continuous professional development credits. They should be learning, adapting, practicing, growing themselves. Now, the standards say that the practitioners are supposed to be reappointed at regular intervals. According to JCI, this reappointment cycle is at least for once in 3 years. Means for your initial appointment, it is for 3 years, and then after 3 years, you are supposed to be reappointed. At the time of reappointment, again, a comprehensive evaluation is supposed to be done. You are supposed to undergo re-credentialing. But here in this re-credentialing, you will not undergo re-credentialing or reviewing of things that do not expire. For example, once you have achieved your medical degree, that is permanent, right? There's no re-verification for that particular thing at the time of reappointment. But if you have any new credentials, new education after the previous appointment, or if you have any sort of certifications, CPDs, things and everything, they are supposed to be re-verified. They are supposed to be verified again. So that's where this re-credentialing comes into play. What happens? What happened in the last 3 years? That's it. Okay, that's where re-credentialing comes into play, or new credentials, new educations, new certifications, or it may be like a renewing of your license. Okay, now, so I hope you got it. What is re-credentialing? Remember, re-credentialing is very much important for reappointment and re-privileging. Now, coming to appointment process. It starts with application. Practitioner submits their credentials and qualifications, their CV, licenses, references, everything, and then they will go undergo primary source verification. of licenses and diplomas. Then they will be evaluated by the credentials committee whether how fit this person is for the organization, whether they will fit the criteria and for that particular role or not. And then finally, the decision will be taken by the governing body. It is a governing body which approves or denies the appointment of the practitioner. Okay, it has ultimate authority for appointments. Now, you as a quality practitioner, from quality perspective, remember each step must be well documented, transparent, and consistent. Here, you can't afford to have unclear or informal processes when you are granting practitioners the right to care for patients, because there might be some sort of legal and ethical issues later on if at all you do not document it properly. All these things are very much important for you as far as quality is concerned. Documentation of all these steps is very much important. Okay. Once practitioners are appointed, they are not appointed forever. Like how I told, they go through reappointment. Okay. So in reappointment, they will review current competency again, how good they are now. Were there any issues that happened in the past 3 years? Any new credentials, new things, and everything, right? Now, we'll evaluate the quality management activities, look at how they participate in quality improvement initiatives. We'll go through their peer review activities. We'll see the findings from their OPP, FPP, and other peer reviews, right? So in short, we'll see like whether this practitioner is safe and effective to practice here with these privileges. Okay, typically occurs every 2 to 3 years, but for JCI, in a way like once in 3 years is enough. Now talking about privileges, like privilege is different from credentialing. How? Credentialing asks like, is this practitioner qualified to practice in general? But privileges asks like, exactly which procedures and services is this practitioner authorized to perform in this particular organization? I hope you got it. There's a difference between credentialing and privileging. Qualified or not is credentialing. Qualified, yes, but what is he authorized? What will he be able to do over in this particular organization is privileging. Okay, so the definition is it's the process of authorizing a clinical practitioner to perform specific patient care services. The purpose is to ensure the practitioners perform only those procedures they are qualified and competent to do. Okay, so the scope of privilege is based on their individual training, experience, and demonstrated competence. Okay, for example, like how like how I told earlier, there may be a surgeon who is not trained in laparoscopic procedures, or let's say he's trained in laparoscopic procedures but he can't do like he's very good at laparoscopic cholecystectomy, laparoscopic appendectomy, but he may not be able to perform complex liver resections or anything depending on his training and experience. So for him, in his privileges, he will be allowed to do laparoscopic cholecystectomy, appendectomy, but as far as hepatic biliary, other hepatic biliary things are concerned, he will not be able to, or he is not authorized to do those things. As simple as that. What is he supposed to do and what he is not authorized to do? That's privileging. Okay, because it is directly linked to the safety, patient safety. From safety standpoint, it's very much important because it prevents the practitioners from their self-assigning procedures that they are not truly trained for. There's no chance that a practitioner who is ambitious enough to perform a new procedure which he is not competent in to try on patients without any sort of guidance or supervision. These privileges will cut them short, right? He will only do what he's good at or what he's supposed to do. There are certain privileges which are there only for the consultant level. The patients get admitted only under the consultants, not under the specialists. As simple as that. The specialists are not privileged to admit the cases independently under them. This stands true for the nursing department also. Even in nursing, there are certain privileges that are given out. A staff nurse is supposed to be doing X, Y, Z thing, but the charge nurse or the senior nurse, yes, they can perform this procedure, they can perform this procedure. All these things are charted out in a privileging form. Similarly, this is done for clinicians as well. Now, there are three types of privilege status. They are temporary, approved, and emergency. Temporary privileges means it allows the practitioner to provide patient care until full credentialing and individual privilege delineation have been completed and approved by the governing body. This is typically used when there's an urgent need for a practitioner and credentialing process is still underway. Remember, temporary privileges should be restricted and be closely monitored. Okay. Approved privileges means these are delineated privileges that have been formally approved for specific time period, usually aligned with appointment cycle. Now, we see these privileges, we told that at least once in 2 to 3 years. So these approved privileges will also be for those things for specified by institution, but never longer than 2 years. Okay. What are emergency privileges? Emergency privileges allow any practitioner to do whatever is necessary to save a life or prevent serious harm within the scope of their license, regardless of membership or privileging status. For example, in emergencies, we all know in case of emergencies, the priority is always the patient's life. We don't stop and say like, wait, you're not privileged to do this particular procedure or this thing. As long as the practitioner is acting within their professional license and in good faith to save the patient, emergency privileges apply. This is important both legally and ethically also. Like we can't wait. I mean, like that particular doctor may be having temporary privileges, or he may not be having certain privileges. But when there is no other medical help available in the emergency situation, and if he performs something which in good faith to save the patient's life, then that is allowed. There, the emergency privileges are given to that particular thing. But remember, he should be under within the scope of his license. For example, if I am a general practitioner, yes, I'm a general practitioner, I'm a family practitioner, my experience lies in it. I can't go on and say, in case of emergencies, also, I can't say I'll be doing something which is out of my particular scope. I can't be doing laparoscopic procedure, even to save the life. Yes, I was in a way like trained to perform minor abdominal surgeries during my residency days, but again, I don't carry that same sort of what do you say practice after those days. I'm not competent enough to perform them, then I'm not supposed to do. But now, let's say, for example, a general practitioner is there. He comes across a patient. Generally, he is not allowed to intubate a patient in emergency, but the respiratory therapist is not available, or if anesthesiologist is not available at that particular time. To save the patient, he may, within his particular license limits, he may intubate that particular patient in ED. That's emergency privileging. Okay. Now, reprivileging. So, just as practitioners are reappointed, their privileges are also reviewed and renewed, which includes review of current competencies and performance. Okay, they will evaluate the practitioner's current competency and performance, and they'll assess, consider quality management data and peer review findings. Okay, and then they will decide whether to renew, whether to revise, add or delete the privileges based on the evaluation. Okay, for example, if a practitioner has had excellent outcomes and no safety concerns, their privileges may be renewed as it is. And in case if he has taken additional training, they might also be granted new privileges. But if there are concerns with his performance data, then certain privileges might be reduced or removed also. Okay, that's where the re-privileging comes into play. So that's what earlier I told: re-credentialing, reappointment, re-privileging. Okay. And like how I told, this particular thing is supposed to be done at least once every 3 years as far as JCA standards is concerned. Okay. Now, what is practitioner profiling? Practitioner profiling is the process of creating practitioner specific data summary as part of reappraisal for recredentialing and reprivileging. Okay. Ideally, practitioner profiling is ongoing process or performed every 1 to 2 years as required for credentialing. The practitioner profile should include information from multiple domains. It's like, say, your file. You are a practitioner, and this is a sort of dashboard. This is a sort of data that is entirely yours. What does the practitioner profile contain? It contains the clinical monitoring data, including the mortality rates, peer-reviewed events with any sort of negative ratings or so. Everything is there. Then it includes the operative procedures, medications, and blood product administration practices that place patients at risk. How did that particular practitioner perform as far as practices that place patients at risk is concerned? How about the healthcare associated infections rates linked to this particular practitioner is? How utilization management findings are, like what are the readmissions and average length of stay for this particular for the patients under this particular practitioner's care, and were there any patient safety incidents? Was he named in sort of root cause analysis regarding any incidents or something? All these things, all these things are put in a practitioner profile. Okay, so this is more of a database, more of a dashboard for a practitioner's impact on quality and patient safety. So remember, this is not about how many patients they see. This is about what happens to the patients which he sees. I hope you got it. Practitioner profiling is not about the business, not about the numbers he's generating, not about the number of patients he's seeing. It's about the outcomes. What's happening to the patients which he's seeing? Okay. So in a way, like if there are high readmission rates and long length of stay, there might be some issues with his discharge planning or care coordination. All right. If there are a high infection rate, then there is some problem with aseptic techniques and device management by this practitioner. Or if we come across repeated negative peer review findings, that might signal us about his clinical judgment or professionalism. So all these things, both qualitative and quantitative data at one place, that's practitioner profiling. As simple as that. Okay. And now that brings us to the end of today's session, the second part of benchmarking, which we have continued from the last session, which we have taken. Okay. So now